Cancer is on the rise globally, and it's closing in on heart disease as the #1 cause of death in the world. Cancer has doubled in the last 30 years. Although cancer is on the rise, studies have shown that many breast cancers are resolved on their own and they simply disappear without treatment. Autopsies show that many people die with an undetected invasive cancer that's not their cause of death. They die from something else while merely having the cancer. How can this be?
It's a very interesting story, isn't it? And part of it is because we don't have a natural history for most cancers, which means that we don't follow a group of people who have cancer and see what happens. As soon as someone gets cancer, we panic, and our tendency is to do something about the cancer.
I know I've heard for years that many times cancers come and go, that people have cancer cells and then they just kind of just go away and they don't really develop into a solid tumor. But I was thinking, and I don't know that, and this isn't a study or anything accurate, I guess, but I was thinking that probably what would set them off or on would be your lifestyle, if you lived a healthy lifestyle.
Oh, we know that's true.
But now they've really done some studies. There are quite a few studies. Tell us about the Dartmouth study.
Well, there was just a recent study published in Archives of Internal Medicine that looked at 110,000 women and studied them over a period of 6 years. And what they did is they looked at them with mammograms every other year. So they did 3 mammograms on them. And so of the 110,000 people, they found about 2,000 cancers. And another 100,000 women, they looked at them, but only did a mammogram at the end of the study. So they didn't do studies along the way. So that if there had been cancers that had cleared, they wouldn't have a way of knowing. However, when they did a mammogram and then compared it, they only found about 1,600 cancers in the second group. So what's happened is that when you follow people over a period of time with lots of tests, you find more cancers.
So it seems like cancers regress a lot more often than what we ever thought. And to me, it seems a little suspicious that maybe the mammogram could have something to do with it, because mammograms do have a lot of radiation.
Well, we know that mammograms do cause cancer. I mean, that's been established. Probably if you do 1,000 or 1,200 mammograms, you're going to cause 1 cancer. And so that's an issue. But aside from that, it wouldn't explain for the 20% of cancers that are different in the group that did not have the mammograms done on a regular basis. So we know it doesn't cause that many. But it was an astounding finding to know that many cancers spontaneously cleared. So we're going to need...
they were undetected, they were untreated, and then they disappeared.
Yeah, and then the autopsy studies that were done years ago showed that about 1 in 3 women between the age of about 45 and 60 had an invasive cancer that was present, that was undetected, that wasn't doing anything. So we know that we need to do more to learn about the natural history. And again, the problem is how are you going to learn about the natural history of how a cancer will be if you don't have a group of, say, 1,000 women who have breast cancer and follow them without treatment? It becomes unethical in the eyes of doctors to let them go.
I'd like to see them do this test screening in a different way than with a mammogram.
Well, there are different ways to do it. When you're looking at the anatomy of what's happening, so you're talking about doing the ultrasound or the mammogram or the CT scan or the MRI, there isn't any question that you're looking at the anatomical finding, but you don't know that much based on what you see in terms of its virulence, its invasiveness, its tendency to spread. So what we need really is a test of physiology, and this needs to be studied because this is only in theory an intelligent way to look at it. So some of the tests that do that, like the PET scans, okay, which are not that good for screening, would be useful in that setting. A test that looks at heat sensitivity, which would be the breast thermogram, would be another real good way to look at the physiology of what's happening there, because there you're looking at a tumor that has a lot of vascularity in it, and it's the heat that's coming out of it and the amount of heat that comes out that tells you what's going on in that tumor. When you're just taking a picture of something, it only shows you the anatomical way that it appears on the study that you're doing. So it may be that finally the breast thermogram is going to get its due, as it certainly deserves, because it is an outstanding test to do, particularly in women that are under the age of 50.
And it's so safe because, well, one of the things that I was surprised about is how much radiation you get from a mammogram, because that's so much more concentrated than a chest x-ray that you get like 250 times more the radiation. And the other thing with a mammogram that can be a problem is the compression of the breast. Now, some people feel that if you have a cancer and you compress the breast that you might spread it. But I know it's difficult for people to hear things like this because we're just bombarded all the time about the importance of getting regular mammograms and clinical breast examinations that are, you know, where the doctors palpate.
Well, we operate out of fear, Vicki, and we don't want to have cancer, and we think of it as a very charged word. It's the big C. And if you've got somebody finds a cancer, the answer is get rid of it as fast as you can. We know, for example, that women who have ductal carcinoma in situ, the so-called DCIS, 98% of those cancers will not kill you. 2% of them probably will. So if you find them, the question is how to differentiate between the ones that are going to kill you and the ones that don't. And that data is hard to get.
It almost makes you wonder if it's better to not know.
Well, that's what's happened in the case of prostate cancer. You know, Dr. Stamey from Stanford invented the PSA test back in the late 1980s. And when it first came out, it picked up a lot of the big cancers that we have. And so it discovered cancers that we didn't know that people had. And for a while, for a few years, that was a good thing. But finally, he came back saying that he thought that the PSA era was over. And the problem is we're diagnosing too many cancers and overtreating people who didn't need it. So we wind up with maybe 95% of the people who have abnormal PSAs being treated for something that they may not have a cancer for.
Well, also I know that they have done autopsies and found that 50% of men, by the time they're 50 years old, 50% have prostate cancer. And they've also found out that 30% of women by the age of 50 have breast cancer.
Yeah, we're talking mostly about cancers in men that are not invasive. And by the way, by the time they're 80 years old, 80% of them have it. And by the time they're 90, 90% of them have it. And you die with it, not from it. And so the question again is how do you know which ones are which? And there are some tests on the horizon that I think are going to make a big difference in both breast and prostate cancer and other cancers as well.
One thing I think it's good to remind people of again also is that just because you're predisposed to a cancer, or you have a family history of it, or you have the BRCA gene or what have you, there have been studies that show that you can change your DNA by lifestyle, by a healthy lifestyle.
We certainly have in the case of prostate cancer. I mean, Dean Ornish did some wonderful studies where he looked at people, this is just a recent study too, done in the year 2008. And what he did is he studied people who had early stage prostate cancer. He biopsied those cancers, and then they looked at the DNA that was in it that was related to cancer promotion. They looked at 500 genes. Then they went ahead and they followed those men over a period of 3 months after doing things like diet, exercise, stress reduction, sleep improvement, yoga, stretching, things like that. And then rebiopsied them at 3 months and found that the 500 genes had changed substantially. So the DNA in your body changes. So yes, lifestyle can make a big difference in what happens in the outcome, and we haven't done those studies with other kinds of cancers because we're afraid to wait to do something because we don't want that cancer to spread.
Well, I think it's wonderful that there's hope. You know, all of this information gives people hope. However, I think it's pretty confusing.
Well, it is, and the state of the art is in a place where we don't really know what to do. I mean, in the case of prostate cancer, at UCSF now, they're looking at what's called an MRI with spectroscopy. That test is $5,800. Medicare does reimburse for it, and so you can get an accurate assessment of how extensive a cancer is, how vascular it is, what its chances are for spreading, and you can follow it over time. But every time you do the test, you're spending $5,800. It's not practical to do that.
And maybe it's turning out that we're overdiagnosing.
There is no question we're overdiagnosing, because if 20 or 30% of people have cancer over a 5-year period, they're disappearing. We're including those people in our treatment studies. I mean, those people would have been well anyway, and they actually aren't very much different from the results that we get from chemotherapy and radiation and surgery. I mean, when you look particularly at radiation and surgery, you're looking at reducing or increasing longevity by, for a lot of cancers, maybe 20 or 25%. Are these the same cancers that are being spontaneously healing by themselves? You wouldn't know.
And then also with breast cancer, frequently people are, have false positives. So the tests turn out that they have cancer when they don't. So then what happens is that they end up having to have more testing and more screening, which also can end up subjecting them to more radiation, and particularly in younger women when cancer can be the most serious, and also when their breasts are the most sensitive, they're more sensitive to the radiation.
Well, there's a lot of arguing going on amongst the medical profession itself, the radiologists and the pathologists and the internists and the cancer doctors, because we don't really know if mammograms are doing any good in women that are premenopausal. So if you've got women under the age of 50, even the American College of Physicians came out and made the statement, these are people from Stanford, saying that each individual doctor should assess each patient individually before making a decision about whether or not a mammogram should be done in a woman under the age of 50. And the reason for that is because there's no clear evidence to show that it saves any lives at all, and there's some question that it may increase all-cause mortality for reasons that we don't understand. So the mammogram clearly, in the women who have the worst cancers, where there's the most loss of life, which is those in the age between 40 and 45, where it's the leading cause of death in women, okay, in the U.S., that's a big factor to consider. So the mammogram in Europe, you know, isn't even done in women that are under the age of 50. They don't start till age 50 and thereafter. And in those women, particularly at age 55 to 70, or maybe even 75, this is a very good test. The mammogram is very good. It does find cancers. The problem is that you can't be sure that when you're finding them, that you want to find them. So it's not the easiest thing in the world to assess. So in younger women, where it's not giving you any positive benefit, they probably shouldn't be done. And in my practice, I don't recommend it. In fact, what we do is we do breast thermography, and that's another story that we've talked about in the past, that I think it finds about 98% of the cancers that are there, and if it tells you have a cancer, it's right about 88 to 90% of the time. So for women under the age of 50, I don't think there's much doubt that's what you should do, and particularly for women who have the BRCA gene defect, or they have a history of breast cancer in their family that is high, or they're at particularly high risk for it. Maybe even at age 20 you want to start doing breast thermography.
Because it's pretty tragic with overdiagnosis. People end up getting overtreated.
Well, 33% of the money we spend in screening is wasted on women who have false positive tests. That's a big number. And the other thing about doing x-rays on women who have the BRCA gene defect is that just one x-ray prior to the age of 20, one chest x-ray prior to the age of 20, in good studies published in mainstream peer-reviewed journals, show that the risk of developing cancer before age 40 goes up 250%. That's just one chest x-ray in that group. So it's not like the x-rays are innocuous. And we know that in women who don't have that defect, that it too increases to some extent. And we've got to look at the big picture of what we're talking about here. If you're talking about doing a mammogram in a woman, you're looking at causing cancer maybe one time out of 1,000. And you may be picking up, doing the mammogram, 3 or maybe 4 cancers. So how much good is it doing? Particularly in these young women is very equivocal. So we need new technologies, and it's not going to be the MRI with spectroscopy, but it's good in prostate cancer. It's coming around to be a test that maybe we're going to consider to use in breast cancer screening as well, but way too expensive.
Some of this is sounding contradictory to me. It's like you want to detect it early because you think that that would be like an early cure. And yet, on the other hand, if you detect it early, maybe it would resolve on its own. And I don't think we know how to decide what it's going to do.
Well, that's what happens when you're not scientific about your research. And clearly, the research in cancer treatments is not scientific. And the reason I'll say that is because we never have a control. We never compare what we do in terms of treatment with people who are untreated. What we compare is one treatment against another treatment, because nobody who has cancer wants to be in the control group where they're not getting the treatment.
They don't want to take the chance.
They don't want to take the risk, and so they're scared. So the fear tactic that's inherent in this system limits the doctors from being able to be scientific about how they're going to go about doing their studies. And when you're in that setting, you cannot get good information, and that's why studies like this, you know, back in the 60s, there was a book on spontaneous cancer regression, and people looked at it and went, wow, isn't that interesting? And they thought, well, just now and then. Maybe you have to go to Lourdes, or you have to have some kind of miracle happen to have this cancer disappear. But now that we're finding out that 20, maybe even 30% of people have cancer, and it's a coincidental finding that doesn't seem to be important, that's kind of a frightening thing.
I remember years ago when I was a young nurse that there was another nurse that worked on our floor, and they told her that her abdomen was full of cancer. And it was Providence Hospital, and a Catholic hospital, and we all prayed every morning together, and we all started praying for this nurse. And the morning that she went to surgery, we were all praying for her. They took her to surgery. They didn't find anything. They opened her up, and there was no cancer in her.
That's interesting. I know some stories that are on the flip side of that. I had a patient come to me in 1997, and she had a very tiny little tumor. It was probably less than half an inch. It was less than a centimeter. And I pleaded with her. I said, just remove it. I think it's the easiest thing to do. Chances are that it'll be cured. Most of the time when you take those cancers out, they are cured. She says, no, I think the power of my mind will do it, and I can do complementary and alternative things. So that's what she did. Well, she lived 7 years, but she died with a rotting cancer that was black and smelly, and it was horrible. And I just had wished that she had listened to me. But how do you really know?
Yeah, it could have been one of those that just spontaneously resolved.
She hoped it would, but the other 70 or 80% don't. And the question is, which ones spread? You know, even the little ones that are less than a centimeter, 25% of those have already spread to a distant site and become metastatic by the time you remove it. So in those 25% of people, the surgery is going to be too late.
So the studies show that if the tumor appears and it's less than a centimeter, which is about a half an inch,
a little less,
by that time it's already metastasized to someplace else in your body. That's pretty scary.
Well,
so by the time you feel it, like they're always talking about the importance of a clinical exam or palpating for it, by that time it would have already spread according to those studies.
That's right. And so what we're trying to do is find newer ways to try to find them earlier. And a lot of the doctors are resistant to looking at that because they don't want to find them early, because they think a lot of them will spontaneously heal. And maybe the smaller they are, the better the chances of resolve. I don't know.
Well, this is a frustrating situation, isn't it?
Well, what do you do is the problem. We do research on animals, and we try to apply that to humans, and it's not the same thing. Or we try to do it in a test tube. We try to see what happens to a cancer that's in a petri dish, and treat it with different kinds of therapies and see what happens. And you never really can apply that information directly back to the human being.
Well, now the pressure and the responsibility is really on the researchers and the medical community to figure this out.
Well, it is, and I feel like our hands are tied. Who's going to volunteer to be in the control groups? We need to either make some breakthroughs in cancer treatment that work, that we can be sure of, and we need to do all the research that we can in all areas. We don't just want to do the conventional therapies that are done in medicine that are toxic. Maybe you don't want the chemotherapy, the radiation, and the surgery necessarily. You'd like to know something that's a little bit better than that, that works, that will then solve the problem. But we haven't done that since we, quote, declared the war on cancer back in 1970 during the Nixon administration. So we're stuck, and we don't have easy solutions for it. So we have to do what we can, I think, preventively. I think preventive health is a huge issue here. We know that people are getting cancer because of environmental toxins and because of lifestyle, because of all the stresses we're under. And I mean, just eating a healthy diet and getting enough sleep and reducing your stress and keeping your weight down, these are powerful factors that make a big difference, including the essential fatty acids in our diets. So we're all getting a couple tablespoons of flaxseed oil, something like the Barlings brand, which I think is a good organic brand. Something like that would be fantastic.
And trying to get the toxins out of our environment and our food and our water and our furniture and our clothes and our cosmetics and all that.
Well, we wonder why we get sick when we expose ourselves to hundreds of thousands of new chemicals that have never been on the face of the planet before until we had the brilliance of creating them. And yes, they all have a purpose that makes our life more comfortable, but they also are insults to the body and to the cellular biochemistry of how we operate. And if we don't take that into account, we're going to see this epidemic grow, and it's why cancer is on the rise. It's not on the decline. And if it's going to soon overtake heart disease, I mean, that's telling us that there are over 600,000 deaths every year in this country from cancer. It's not all cigarettes either, even though that's a big part of it.
What do you think of this Dr. Epstein, who's the chairman and the president of the Cancer Prevention Coalition, who thinks that mammograms are a crime against humanity? That's a pretty strong statement. He feels that it's very political. What do you think about his opinion?
Well, I mean, that's interesting. I would hate to think of what an oncologist or a radiologist would think of that, because
probably click
that's
this
what they
channel
do.
off
Yeah,
quick.
let's change the station quickly. But I think he's got a point, because when we overdo something that does cause cancer, that is equivocal about having any value at all, and then stand on our podium and start preaching to the public about getting your annual mammogram every year between the ages of 40 and 50, I think that that's pretty aggressive. And when you've got a whole industry standing behind that profits from it, that's Epstein's point. He's saying that whenever there is a profit that is the primary motive, which I think there might be from the industry itself, because the industry is around for what reason? It's to make money for their stockholders. Yes, of course, it's to provide a service if they can, and of course, if they can, that's a beautiful thing, because that combination is a wonderful combination for making a product that we all want and need. But when you are suppressing other disciplines, other technologies, because of it, particularly in women under the age of 50, I agree with them. There have been needless deaths of thousands of women because we haven't been able to pick up these cancers early.
And quality of life. Quality of life is so important, and so many times people are promised a longer life if they do these treatments, but sometimes the longer life is only a couple of months, and if it's only a couple of months and you're throwing up and you're weak and you're tired and your hair's all falling out, what kind of a quality of life is that? If that's only a temporary thing and then you do get better, well, then that was probably worth it.
I've talked to a lot of women who have breast cancer, obviously, because I'm a doctor and I see people who have that. And most of them who have gone through what they've gone through really have a problem with the chemotherapy. They get, a lot of the time, their feet go numb. They get peripheral neuropathies. They lose their energy 30% of the time, and it can last for decades.
And we're talking big-time fatigue, not just saying they're kind of tired. I've heard stories where people that have cancer that are undergoing chemotherapy, sometimes they'll like barely make it to the bathroom and then end up just lying on the floor because they're too tired to make it back to their bed.
Yeah, and then on the flip side, there are some that do very well. And you have to admit that the doctors, when they do their research, they're taking one group that they're treating with one treatment and another with another treatment and seeing what the outcome is. And it's not all spontaneous remissions that are accounting for that, because that should be in both groups. And it's not, but it's not accounted for either. So this whole business of cancer chemotherapy and radiation and the diagnostics and the other treatments that are done is something that we need a lot of work on. We need to do more research. And we're not getting far with the approaches that we're taking. So we're in a quandary. We've got a disease that we don't really have a solution for a lot of the time. And it's not to say that there aren't some wonderful chemotherapies and radiation and surgeries that cure people and give them a wonderful, meaningful life. There are.
Well, one of the things that I was thinking of is that a way to differentiate the type of cancers to see if it's the type that might disappear on its own or what have you might end up being from biopsy. However, there's a drawback with the biopsies because many studies show that the biopsies can make it spread.
Well, those studies I've looked at very carefully, and I remember one being published in Archives of Surgery in the year 2004, and basically what that article showed is that if you did a breast biopsy, even with a fine needle or a core needle biopsy, which is a bit bigger, the risk of metastases went up 50%. Now that's a big deal, But I've been in touch with that doctor since that time, and she's recanted that, but it hasn't been published yet.
Oh.
So it's probably not true. I think biopsies are probably safe. And the whole study of how does a cancer spread...
Of course, if you're thinking about puncturing a capsule, though, it does seem like it could leak out, but of course that's not scientific. That's just
no,
what I think.
that's good thinking. It just turns out to not be true. You will spread cancer cells when you do a biopsy every single time to the local tissues. But it's not the same thing as having the tissues be able to support the growth of the cancer. There's a lot involved in cancer metastasis that's not just putting cells in different parts of the body. For example, why does a breast cancer just spread to bones, or sometimes just to the brain, or sometimes to the liver or to the lungs? There are specific things that the receiving areas where the cancer goes has to prepare itself to allow that cancer to grow. And just spreading it locally into the area where the cancer is not enough to make cancer spread and become invasive that way. So we're looking at something that's a very complicated field, and we need a lot more research to understand what makes a metastasis possible. It's not just simply the spreading of cells from one area to another.
And we were talking about breast thermography, which is a very good way to detect cancer. It does it earlier than mammograms. It's particularly good for younger women where cancers are more difficult to detect with a mammogram because the breasts in younger women are very dense. So if people are interested in learning more about breast thermography, we also call it mammotherms. You can go to www.alternativehealth.com.
And get more information about it. So that's a good way to learn and get information that you need to know how to take care of yourself better.
Thank you for joining us.
I'm Dr. Len Zabuta.
And I'm Vicki. It's important that we take responsibility for our health by living a healthy lifestyle and learning what's new in the news in medicine.